For this video, we will be discussing agents used for the treatment of rheumatoid arthritis, or RA, and we will add a number of additional immunosuppressive agents to your list of ones we have already discussed in this block and in other blocks. And before we dive into the mechanism of action and pharmacologic considerations for each of these agents used to treat RA, we will first go over a very simplified overview of the pathophysiology behind this disease. So RA is a chronic inflammatory systemic autoimmune disorder that's characterized by this erosive synovitis that leads to joint destruction, deformity, and dysfunction. And like most autoimmune diseases, the exact etiology is unknown, but it is thought to be multifactorial, including a number of genetic and environmental factors that somehow these factors lead to antigen-presenting cell or APC cell activation and their release of cytokines like tumor necrosis factor alpha, which we've talked a lot about before. And there's also this inappropriate presentation of synovial-related autoantigens to activate naive T cells. And one important point for later in this video is that these antigen-presenting cells express CD80 and 86 on their surfaces, and this can bind CD28 on those T cells, and this interaction will lead to a more optimal T cell activation. So these activation signals lead to that release of interleukin-2 that we've talked about before, further perpetuating this T cell mediated cascade, eventually leading to the release of other cytokines promoting the recruitment and activation of B cells, which will differentiate to become those plasma cells that then will produce those autoantibodies characteristic of RA, being either rheumatoid factor or anti-citrulline protein antibodies. And you might see this abbreviated as ACPA. And then these autoantibodies can recognize their respective autoantigens within the joints, thereby forming these immune complexes, promoting inflammation and further cartilage and joint damage. Now remember, activated T cells also secrete cytokines like tumor necrosis factor alpha and IL-6 that recruit and activate other immune cells like the macrophages, which I'm showing you here, which can also secrete these same cytokines as well as interleukin-1. And these can then act upon other cell types like the fibroblast-like synoviocytes, which can then secrete their own inflammatory mediators and matrix metalloproteinases that can cause further joint damage and immune cell recruitment. So another group of cells that are activated by this immune cascade are the osteoclasts, which remember are the cells responsible for breaking down bone. So their activation is going to contribute to the bone erosion and the joint dysfunction. So over time, all of these effects are going to lead to joint damage, synovial hyperplasia, and angiogenesis. There's also going to be cartilage and bone destruction, and leading to this impaired quality of life for the patient. So moving to the next slide. So based on this disease mechanism, the primary goals of treatment will revolve around improving and maintaining joint function, improving quality of life, and preventing further damage, and ideally achieving remission. And to do this, a number of immunosuppressive therapies are applied to this indication, spanning from the biologics to the more traditional immunosuppressants to the small molecule inhibitors. So similar to previous immunosuppressant videos, we will start off with agents working outside or on the surface of our immune cells and work our way intracellularly, which means the first agents we're going to discuss are going to be our biologics. So because most of these agents are going to share a common set of pharmacologic considerations, and they have been covered in previous videos, like our risk of hypersensitivity, our infusion reactions, the risk of infection and malignancy, etc., so for the sake of time, I will only list concerns that fall outside of this common list of adverse drug reactions to be aware for and monitor for. So we will start off with some of the agents that will hopefully look familiar from the IBD video in Block 3, being the anti-TNF alpha monoclonal antibodies. So remember that TNF-alpha, which is a key inflammatory cytokine you have seen in other videos, is going to be this potent inducer of inflammation and is released by a number of immune cells involved in autoimmune diseases. One example of an anti-TNF-alpha monoclonal antibody would be infliximab, which is Remicade, or for instance, adalimumab, which is Humira, and there are several others. And these monoclonal antibodies will bind and either neutralize soluble tumor necrosis factor alpha and or bind the transmembrane form on immune cells, triggering their apoptosis, and this will reduce inflammation and circulating immune cells to improve RA. Now, etanercept, which is also known as Enbrel, is another anti-TNF-alpha targeted agent we have yet to discuss. But instead of being a monoclonal antibody, Enbrel is a fusion protein combining the tumor necrosis factor receptor, hence the sept in the etanercept name, with the Fc region of IgG. And it was developed to essentially neutralize tumor necrosis factor alpha, rendering it biologically inert. So it cannot perpetuate this immune response. So Enbrel comes with a risk of hepatotoxicity, as well as concerns for cardiovascular events. And this risk of cardiovascular events is actually common across all of the tumor necrosis factor alpha targeting agents. And these TNF-alpha targeted agents are usually for more moderate to severe RA cases. Another agent that should look familiar is rituximab, which remember is a chimeric monoclonal antibody which is targeted at the B cell population, specifically CD20. And remember, CD20 is an antigen found on pre and mature B cells, and when bound by rituximab, it will induce apoptosis of these targeted cells so that they cannot become plasma cells to secrete those autoantibodies that are a significant driver behind the inflammation in RA. So one thing you will notice when researching rituximab is that it has a much longer list of precautions and adverse drug reactions like edema, hypertension, GI concerns, cardiovascular events, and many others. And for these reasons, it is used more for those moderate to severe patients that have failed another therapy, for instance, a TNF-alpha inhibitor. So our next group of agents we have not discussed yet. And one example is tocilizumab, which is also known as Actemra. And these are going to be monoclonal antibodies that are targeted at the interleukin-6 receptor. So remember, interleukin-6 is produced by a variety of cell types that are involved in RA and promoting this inflammatory process that's going to lead to that joint damage. So these agents will bind the interleukin-6 receptor and inhibit interleukin-6 mediated signaling via these receptors. So we're going to prevent that inflammatory cascade downstream. So these agents do come with a risk of hepatotoxicity, GI issues, hypertension, lipid abnormalities. So these patients will need monitoring, and this agent is usually more for moderate to severe disease in patients that have failed other agents. So our next agent is like Enbrel in that it is a fusion protein, and it is called abatacept. Again, we have that sept ending, and it is also called Orencia. And it is a fusion protein of the cytotoxic T lymphocyte antigen, or the CTLA, which is normally a negative T cell regulator. And this is linked to an IgG Fc region. And how this fusion protein works is by binding CD80 and 86 receptors on our antigen presenting cells and preventing their binding to CD28 on the T cell. So we prevent that optimal T cell activation and we dampen that T cell mediated response in RA. So Orencia comes with a risk of hypertension, as well as COPD exacerbations. and is usually, again, used for those patients with more moderate to severe RA, again, those failing other agents. And then on to our last agent to introduce on this slide, which is anakinra, or Kineret, which is a recombinant form of interleukin-1 receptor antagonists. So remember, interleukin-1 is produced in response to inflammatory stimuli. It mediates various inflammatory and immune-mediated responses and is involved with this cartilage and bone destruction. So interleukin-1 receptor antagonist is secreted to counteract the effects of interleukin-1 and antagonize those interleukin-1 receptors. So in RA patients, the levels of endogenous interleukin-1 receptor antagonists produced by these various cell types is not sufficient to actually compete with the elevated amount of locally secreted interleukin-1. So anakinra acts to supplement the endogenous interleukin-1 receptor antagonist levels and inhibit that interleukin-1 action. So unfortunately, unlike the other agents on this slide, this agent does require daily subcutaneous dosing, which is not ideal. And because the clinical data is insufficient to recommend using it over other agents, it really isn't used very much anymore. So moving to the next slide. I know in this video I haven't focused on as much the antibody naming, but I would encourage you to go through the slide with the monoclonal antibodies and go through and determine if it's human, humanized, chimeric monoclonal antibody, and what its potential target might be. But now that we've discussed all the antibody-based agents used for RA, let's move inside the cell and discuss the remaining agents that we will cover in this video. So moving to the next slide. Since we just went over the mechanism of action and important pharmacologic considerations for steroids, methotrexate, and hydroxychloroquine in the SLE video this week, we will not rehash those for the sake of time, and we'll move on to the other three agents or groups of agents that we will discuss in this schematic. So the first agent that we will discuss, we actually talked about a little bit a while back, and that agent is sulfasalazine, which is a part of the aminosalicylate drug class, which can be used for the treatment of RA. And this agent is delivered in its prodrug form to be cleaved into a sulfapyridine metabolite as well as 5-ASA. Or 5-aminosalicylic acid. And remember, the mechanism of action of aminosalicylates is not fully understood. So it's thought at least that the 5-ASA portion of these agents may inhibit the conversion of arachidonic acid to either leukotrienes and prostaglandins, which is mediated by cyclooxygenase enzymes and lipoxygenase enzymes. So it's thought that these agents play a role in this inhibition. However, only a very small fraction of the 5-ASA is actually systemically absorbed, and it is thought that the sulfapyridine metabolite portion of sulfasalazine is actually the anti-rheumatic agent, but it is unclear how it actually modulates its immunomodulatory effects. Unfortunately, this sulfapyridine metabolite can cause allergic reactions, and this agent is contraindicated with a sulfa allergy. And this agent does come with a number of other adverse drug reactions, and because it is not as well tolerated, methotrexate is more commonly used if a non-biologic disease-modifying anti-rheumatic drug or a DMARD is needed. Now moving on to our next agent. So on this slide, I just want to revisit the JAK inhibitors, or the Janus kinase inhibitors, which we have discussed before. And in the context of RA, this is going to include Xeljanz or tofacitinib, as well as others like Rinvoq and Olumiant. And remember, this NIV ending signifies that it is a small molecule inhibitor. So these agents are going to inhibit Janus kinase or JAK kinases, which are intracellular enzymes coupled with the cytokine receptors. So When these small molecules aren't around, the cytokine will bind, and this will lead to the phosphorylation of STAT, or signal transducers and activators of transcription, and this phosphorylation is carried out by JAK to trigger their dimerization and the nuclear translocation. Again, this will lead to the transcription of pro-inflammatory genes and other regulators of immune cell function. So with JAK inhibitors like Xeljanz, this cascade is inhibited, preventing that phosphorylation of STAT so that these genes are never expressed, preventing proper immune cell function and production of inflammatory mediators. Now, the concerns and adverse drug reactions of JAK inhibitors are very similar to the other agents that are immunosuppressants, where this immunosuppression is going to lead to an increased risk of infection and malignancy, and this is also going to affect some of those rapidly dividing cell populations too. There's also a risk of major cardiovascular events with these agents, and it is pretty expensive. So this is usually used after failing another agent. So moving to the next slide. And the final agent for this video will be leflunomide, which is a prodrug, and after administration, it is metabolized rapidly to its active metabolite, teriflunomide, which demonstrates immunosuppressive effects through its inhibition of dihydroorotate dehydrogenase, which is an enzyme responsible for mitochondrial de novo pyrimidine synthesis. So by depleting these pyrimidine pools, there is an inhibition of immune cell proliferation and function. So the downside to leflunomide is that it has a very long half-life, where a loading dose is going to be required, followed by a maintenance dose after. And because of the long half-life, if it needs to be stopped, there is actually a drug elimination procedure to help speed up its clearance from the body. So this drug is also teratogenic, and it is contraindicated in pregnancy. And so sufficient contraceptive counseling is going to be really important, and the drug elimination procedure is needed prior to conception. So there's also a risk of hepatotoxicity, hypertension, and edema, and other concerns. And these, along with the high cost of this agent, make it less common and ideal. So moving to the next slide. Now this brings us to our summary slide for agents that are primarily targeting intracellular immune cell components. So moving on to our final summary slide. Now I hope this video has introduced you to a few more staple immunosuppressant agents that we will likely revisit in this block, as well as a few specific agents used mostly for RA. And hopefully this video, as well as the SLE video, has showcased why understanding the important immune mediators, whether it be cell type or cytokines involved, can help you better identify agents likely to be indicated for certain autoimmune diseases, and not so much for others. So I also hope our discussion helps to continue reinforcing the pharmacologic similarities across groups of immunomodulatory agents, like their mechanism of action and adverse drug reactions, that will continue to help you organize the different immunosuppressants.